जी हेलो हेलो आ रही आवाज़ अच्छा अस्सलाम वालेकुम मेरा नाम डॉक्टर यासिम है आज का लेक्चर जो है इट्स गोना बी अबाउट सर्जिकल इन्फेक्शंस ठीक है in which we will also be discussing sepsis what is sepsis उसकी prophylaxis treatment क्या दे सकते हैं sepsis के provided कि जो हमारे पास enough evidence नहीं होती but based on suspicious symptom signs of the patient जो है उसके हिसाब से क्या प्रोफिलैक्सिस ट्रीटमेंट शुरू कर सकते हैं और व्हाट इज सेप्सिस स्क्रीन ठीक है ओके तो what is infection basically in broad terms infection with it's a process whereby microorganisms take it which can include bacteria viruses and fungus ठीक है whereby microorganisms with an innate capacity to cause disease either by invasion or toxin production ठीक है in sufficient amount of numbers ठीक है उसकी जो organisms have they should be present in sufficient amount of numbers to cause a reaction in the body in order to fight it ठीक है उसके दौरान जो है the microorganisms try to gain access and breach the body's defensive barriers and then उसकी वजह से जो है there's a whole inflammatory response which is produced by our body ठीक है that results in basically trying to overcome the injury or the damage to the body or its tissues. That's just the basic broad terms of infection, basically how it presents in a body, what is going on at the cellular level. Further, if we dive into the physiology of it, again, there are microorganisms that are normally prevented from causing infection in tissues by intact epithelial surface. So a sort of barrier जो है हमारी बॉडी में वो है epithelial surfaces जो skin है basically जो वैसे ही काफी सारे microorganisms को prevent करती है in order to gain access into our body which can further break down in trauma or by surgery. Other protective mechanisms can be divided into either chemical, so having a low gastric pH is efficient in that sense. Hormonal, humoral, basically antibodies and complement, and along with those opsonins, which cause the cellular phagocytosis of the antigens that present on macrophages. Cellular level of weak phagocytic cells that include basically macrophages, polymorphonuclear cells, and also killer lymphocytes. So again, basically just highlighting the normal physiology of our body that prevents the normally prevents the microorganisms from causing infection in our body. Now, causes of reduced host resistance to infections. What are some of the causes? इसमें जो है you could have some metabolic issues that can be either due to malnutrition. If we don't have enough nourishment, we don't have enough vitamins in our body, or either you're obese, even obesity. Obesity may be malnutrition. Along with this, obesity can also present with diabetes or the other way around. Along with also uremia and jaundice. So these are the metabolic disorders that can occur in the body that can cause a decreased host response to infections. Along with this, we can also have a disseminated disease, a cancer and acquired immunodeficiency syndromes, AIDS, so these are forms of disseminated diseases that can also affect our immune system. Then there's iatrogenic, unknown to this. The radiotherapies, they can cause it. Chemotherapy, people that have cancer that undergo either one or both, and along with steroids as well, they reduce the efficiency of our immune system, try and suppress the immune system. Just patients that have undergone transplants, they are basically prone to infections because they're given steroids initially, post-operatively transplant, post-successful treatment. Okay. रिस्क फैक्टर्स फॉर wound infection क्या हो सकती हैं? वो है कि colonization and translocation in the gastrointestinal tract, ठीक है, HPO, poor perfusion, ठीक है, systemic shock or local ischemia उस जगह पर होगा, foreign body material, ठीक है, that promotes, basically these are all factors that promote infection and do not have effective wound healing processes. Poor surgical techniques, dead space अगर छोड़ दी और hematoma collection इस तरह का form हो जाए जिस जगह post operatively drain नहीं पेश किया जिससे you perform a procedure जहाँ पे अगर dead space ज़्यादा है मतलब कि if you are excising a mass suppose तो उस जगह पे जो है after you've excised a swelling or a mass say it was a giant you know, either lipoma or any other swelling that you took out, it's better to leave that space open for secondary intentional healing. Yeah, place some drains in that area that will drain the collection of serous fluid that might accumulate if you had primary sutured and primary closed it, and also result in poor surgical techniques. As a result, it will form wound infections. Now, definitions of infected states. Okay, this major common, I'm sure a lot of you have already heard, is SIRS, Systemic Inflammatory Response Syndrome. Because the body's defensive response to an acute serious systemic illness. Okay, you need two of the following: hyperthermia, 38 degrees Celsius temperature is ज़्यादा, or hypothermia, less than 36 degrees Celsius. Tachycardia, heartbeat more than 90 minutes, patients not on doctors, or tachypnea, breathing, respiratory rate more than 20 breaths per minute, along with white cell count, TLC, more than 12, or less than 4. So sepsis is systemic inflammatory response syndrome with a documented infection. Infected states, we get a definition. We have severe sepsis or sepsis syndrome, the MOD or MODS, which stands for multiple organ dysfunction syndrome or multi-organ dysfunction syndrome. It's a form of sepsis with evidence of one or more organ failures. One or more organ failures associated with sepsis results in MODS. This respiratory involvement was that will cause acute respiratory distress syndrome. Cardiovascular, heart involvement was that will cause septic shock, follows compromise of cardiac function and fall in peripheral vascular resistance. Could affect your kidneys, the renal, usually acute tubular necrosis, picture C, hepatic, liver, blood coagulation system, or central nervous system. Bacteremia is the presence of bacteria in blood, and septic shock is shock due to sepsis. These are basic definitions of the infected states that are commonly used and you will see in your books as well. Septicemia is an absolute term. Septicemia. Obsolete term. It used to be used commonly, but now it's not. More often you'll see bacteremia and septic shock. MSOF or multi-system organ shock is the end stage of uncontrolled MODS. It's the end stage of MODS basically. Initially, you would have the multi-organ dysfunction. Once the organ is dysfunctioning, it is not able to perform its normal functioning capacity, will eventually result in complete organ failure. So that is a more serious form of organ dysfunction, meaning it results in complete failure of the organ to function normally. Yeah, surgical infections. Surgeons usually encounter infections in two ways. If you're looking at a patient who presents with an infection that requires surgical treatment, example, abscess drainage, as you can see in the picture on to your left, or in the other way, which means infection complicates a surgical procedure. The post-operatively trauma wound infection, that's the other form. Basically, initially present in the form of an abscess that will result or definitely need a form of surgical intervention. Or B, on the right picture as shown, it's a complicated wound, meaning it's been has complication in the sense that the wound site has been infected now. Now, sepsis screen. It's a screening protocol device to find the cause of SIRS or sepsis. Okay. Sorry, one second. Just yeah. Yeah. Okay. Sepsis screen. So the most important things are blood. You need the whole complete blood profile needs to be done. So a full blood count. Full blood count is necessary. What we'll see is the white blood cell count, TLC, whether it's raised or not. ESR will also be necessary. Sorry, one second. Zoom it up. जी वाले समझो मैं लेक्चर दे रहा हूँ कोई इम्पोर्टेंट नहीं चलो से after. Sorry about that. Yes. The full blood count, what else is necessary is basically ESR, which is what erythrocyte sedimentation rate, that's what it stands for. If there's any form of inflammation in the soldier body, usually this is raised, and I believe the cutoff value is around 10. Next is urea and electrolytes. TK will give you a definition of the dehydration of the patient, whether or not, or even the renal function. How are the kidneys performing, which is also essential. If you're going to further give him antibiotics or anything, you need to know about the renal clearance of the drugs as well. And also gives us a good indication of how far the sepsis has progressed. CRP, C-reactive protein, another marker of inflammation and infection in the body, and is usually raised when there is presence of any of the two, along with blood cultures, in which we find out exactly what bacteria was responsible for the sepsis. So from the blood profiling, this is necessary for screening of sepsis. There are other tests that you can perform. However, these are the necessary ones that you should perform. इसके साथ जो है, then there's radiology में chest X-ray to rule out pneumonia in any way. In any case, urinalysis again to rule out UTI, urinary tract infection now. And if you're still unsure, इसके साथ जो है throat swab is necessary. Take a laryngitis, and a stool culture should also be done. Strictly, this should be part of any septic screen because it's usually reserved for those with diarrhea. Yeah. Management जो है sepsis 6 मतलब क्या? There's 6 things that you need to do for anybody with sepsis. Okay, and these 6 things should be done within 1 hour. Okay, the patient presents from 1 hour from entry into ER or hospital. 1 hour from there on. Then this should also be done in this order of priority. You go first blood culture, then antibiotics, hit oxygen, hit fluids, collected, catheterize the patient last. So these are your 6 things that are necessary. Blood culture, wait again before antibiotics are administered because they can. If you give antibiotics first, then they'll give you a false idea of the blood culture. It renders it pointless basically. If you take blood culture after the patient was given antibiotics. So antibiotics is probably the most important thing they get following the blood culture. Mortality is reduced by 50% in severe sepsis if they're given within an hour of diagnosis. Throughout the whole process, in sepsis 6, speed is important. How quick you are. That's why it should be treated as an emergency and urgency, and every order should be carried out in the least amount of time as possible. Oxygen, that's also necessary. Even if oxygen saturation appears adequate, you still need to give 100% oxygen at 15 liters per minute, the maximum via a venting mask or a mask. If there is severe sepsis, obviously. Fluids also necessary. Highly likely to develop hypovolemia as happens, the inflammatory response leads to fluid shift into the tissues. So the fluid will be shifting from your capillaries and arteries into your tissue. That will result in hypovolemia and hypovolemic shock. Fifth thing is like a sign of anaerobic respiration, and it's bad. Lactate starts to build up. Lactate above 2 indicates impending acidosis. And then catheterize the patient. If you need to monitor urine output and hourly urine output measurements. So this is a good prognostic step, basically catheterizing the patient and observing its urine output. Now, moving on. Infection that requires surgical treatment. Infections that require surgical treatment. इसमें जो है obviously when we're looking at infection that require surgical treatment, उसको differentiate कर सकते हैं into two broad categories. A localized infection या B specific surgical infections. ठीक है. Localized में क्या आ सकता है? Could be abscesses, cellulitis, bronchial, lymphangitis. ठीक है. Specific surgical infections में जो है other than gas gangrene, Clostridium tetani, synergistic spreading gangrene as well. Now, we'll first look at the localized infections, and broadly abscesses, cellulitis, and lymphangitis. Abscesses it's a localized collection of pus, usually surrounded by an intense inflammatory reaction, forming a ring around the abscess, a wall around the abscess. It cordons it off from the remaining tissue, or उसमें जो है dead collection of cells जो है जमती रहती जो basically the definition of pus. And it presents with all the clinical features of acute inflammatory response. Originally described by Celsus in Latin words, as this described, is calor, which means heat. Rubor means redness. Dolor means pain, and tumor, मतलब swelling. To these can be added functionalism, meaning loss of function. That can also be added along with the others. Calor, rubor, dolor, and tumor. Meaning obviously loss of function is not as a result directly, but maybe because of the pain that is caused by the infected part, resulting in loss of function. The full capability of that limb, arm, wherever the abscess might be. Alright. There's a picture of an abscess. So as you can see, it's neck anterior part, sort of lateral part of the neck. It's quite large, and what you can note, the important things in this is what basically the 4 to 5 Latin definitions that we just described. Calor, rubor, dolor. Obviously, calor you can't observe. You're going to have to examine. So from the back of your fingers, if you were to place your back of the fingers onto the swelling, you would note that its temperature would definitely be raised. Obviously, there's a definite swelling. There's inflammation. So we can observe at least 2 out of the 4 findings. What is this? This is boils and froncles. You have multiple small collections on the superficial epidermis. These are froncles, which is the infection of the hair follicles. Usually, in between each of them, you can see there's the hair follicle rising up. This is a carbuncle. A carbuncle, usually there are almond sites for all of these. Usually around the areas where there's sebaceous secretions and hair follicles. Carbuncles, however, more commonly seen in a advanced sort of abscess that has become even worse over time. That's not being treated adequately enough, and also more often seen in patients that have diabetes. The way to differentiate between a carbuncle and, like, say, a sebaceous cyst or something is carbuncle has multiple openings, as you can see. There are multiple punctums, not just a single opening out here. There's multiple sites where you can see there's pus definitely within. And all of these open up into a large sort of cavity where there's pus within. This is an hidradenitis suppurativa, usually commonly seen in axillary regions involving the lymph nodes and not lymph the your glands in the armpits, axillary regions. So abscess, like I said, is a pyogenic organisms involved. You get predominantly which one Staphylococcus aureus, obviously, and causes tissue necrosis along with separation. Pus is composed of dead and dyed white blood cells. Okay? Abscesses contain hyperosmolar material that draws the fluid in. This increases the pressure and followed by pain. This image will have macrophages, angiogenesis, and fibroblasts, all cause formation of granulation tissues. And later forms a suppurative process around it and leads to a collagen deposition as well. And if it is not drained or resorbed completely, this abscess can become chronic. And if it is partly sterilized with antibiotics, an antibioma can form as well. The antibioma will result in basically further granulation tissue formation around the swelling. It completely walls it off, and the swelling doesn't subside, and it just forms an antibioma. So this definitive treatment is definitely drainage in order to completely resolve this abscess. Usually what we do, sometimes surgeons prefer before incision and drainage, or drainage of the abscess, usually give the course of antibiotics before proceeding to reduce the inflammation in that area. It not only helps in the post-operative treatment of the abscess drainage, but also a healing process post-operatively as well. All right, here's a picture of the abscess. In the center, the core is the pus. Around it, you can see there's a ring of tissues around it. Right next to the pus is the pyogenic membranes of the pus. It's usually beneficial that we remove it, clean the wound, clean the area, make sure none of this membrane is left behind as well. Followed by this pinkish tissue, the granulation tissue, and surrounded by that is the fat and the skin on top. Fat on the bottom, skin on top, superficially taken. And if it were to form an antibioma, it would definitely be around this pyogenic membrane involving the granulation tissue. All right. Abscesses, if they were to spread, they usually do so and track along the planes of least resistance and point towards the skin. So they always come out towards the skin. That's why you see the little the clear pus type superficially on the epidermis, because that's the plane where there is least resistance, and it tries to release the pus from within by pointing outwards towards the epidermis, and eventually some of them do burst, and the pus is basically drained out of the wound. Wound abscesses may discharge, take it spontaneously by tracking the surface, or else they might need to, if it cannot track itself all the way up to the epidermis, then obviously surgically you have to incise and drain the abscess. Along with abscess drainage, we need to cure it. There's a surgical tool that we use. It's called a curette. No, there's not a picture here, but we use that surgical tool, curette, to clean out the margins inside of the wound as well, to get rid of all the other membranes and all the other, to break the loculi as well if there are multiple subtypes with different depths. So it also, it cleans out the wound. Not only does it do that, but also prevents the recurrence of infection in that area. Antibiotics are indicated. Obviously, the abscess is not localized. It's spreading within cells and tissues. So if there's evidence of cellulitis, then antibiotics are indicated as well. And healing by secondary intention is encouraged. Secondary intention will leave the wound open. You don't suture it close. You leave it open and you dress the wound. Dressing. You do daily dressing with any of the solutions. Whether it could be Usol, iodine, disinfectants, address the wound. Let's see. Next, cellulitis, like we discussed, antibiotics usually indicated when you have a cellulitis, okay? And it's defined as an infection of the subcutaneous tissues and lymphangitis, which is spread of the infection along the lymphatic channels, producing characteristic red lines of lymphangitis. I believe we do have a picture for that. So if you have a cellulitis, which is the infection of the subcutaneous tissue, it can spread to the lymphatic channels, which will further cause lymphangitis. Lymphangitis characteristically, you'll see the red lines of lymphangitis and enlarged tender nodes to which they drain to of the acute lymphangitis. Non-suppurative, they're usually poorly localized, commonly caused by streptococci, staphylococci, or Clostridium. SIRS is common, and blood cultures are often negative in cellulitis. Here we go. This is a picture of cellulitis. Now remember those cola, rubeola. You can see there is rubella, there's swelling definitely. There's one again, rubella raised hanging. You can see if you're comparing it to this, which is part of the normal skin, compare this. You see the borderline right here. This seems, and it is basically a little raised compared to the normal skin out here. Along with that, there is inflammation. See here, there's redness or pain due to the patient's. Right. Yeah. Here we have lymphangitis. Now, in this, obviously, there was cellulitis to get an infection of the subcutaneous tissue, but led to lymphatic drainage of those cells from that infected site, caused lymphangitis, infection of the lymphatic channels. So over here, you can perfectly see how it was initial involvement, most likely out here, which led to drainage of that area along this tract right here, draining into these axillary lymph. Here we have another slide of lymphangitis, again depicting the classic presentation of this, where you can see redness, and inflammation along the characteristic sign of lymphangitis. Draining right into the lymph nodes, basically. Specific surgical infections. Specific surgical infection like gas gangrene, Clostridium tetani, and synergistic spreading gangrenes will be discussed. What is gas gangrene? This is usually caused by Clostridium perfringens, right? And these gram-positive anaerobic spore-bearing bacilli. They're usually normally found in nature in soil and feces. It's relevant to military and traumatic surgery and colorectal operations. Patients who are immunocompromised, diabetic, or have malignant diseases are at greater risk. If they have wounds containing necrotic or foreign material, resulting in anaerobic conditions. There we go. This is most likely gas gangrene. You can see multiple bulla as well out here. Along with that, what else do you know? There's obviously obvious amount of discoloration. There's redness, inflammation. There's swelling, large amount of swelling. Obviously, there's inadequate flow and outflow of blood via arteries and veins, respectively. Okay. Obviously, there's a gas gangrene going on. Gas in the tissue also can be noted on plain radiograph X-rays, where out here, large, small, black shadows out here, small circular, and on the superficial side as well. Let's get these are all gas gangrene. Gas gangrene wound infections are associated with severe local wound pain and crepitus. What is crepitus? Crepitus is usually a gas that develops inside tissues. Obviously, there's gas gangrene that's going on, but gas cannot escape. There's no break in there. So it will be deposited within the tissues and can also be noted in thin radiographs, like we just saw earlier. This is all gas being deposited in these subcutaneous tissues. This is known as crepitus. Crepitus can also be observed. Cannot. It's better. This is a sort of a sign that you can find out examination. Or it can be noted with plain radiographs. Now, the wound produces a thin, brown, sweet-smelling exudate in which gram staining will reveal bacteria. And human spreading gangrene followed the release of collagenase, collagenase, other proteases, and toxins. Early systemic complications with circulatory collapse and multisystem organ failure follows. The antibiotic prophylaxis should always be considered in patients at risk, especially when amputations are performed for peripheral vascular disease with open necrotic ulceration. And once gas gangrene infection is established, large doses of IV and aggressive debridement of affected tissue is required. The use of hyperbaric oxygen is controversial. What is hyperbaric oxygen? Is basically you put you in a tube in which there is oxygen. It's said to promote wound healing and all sorts of things, but it's still controversial. What is beneficial is what antibiotics take it prophylactically should take it. That will considerably reduce the risk of the patient, but that's not enough. What else you need to do along with that is give intravenous penicillin, and along with that, the important thing also that goes with it is aggressive debridement of the tissue that is involved. Clostridium tetani. Okay, this is another anaerobic terminal spore-bearing gram-positive bacterium that can cause tetanus following implantation in tissues, or one which may have been trivial or unknown as a forgotten. Now, the spores are widespread and normally swile. The signs and symptoms of tetanus are mediated by a release of mycotoxin, which is tetanus plasma, which affects the mioneural functions and motor neurons of the anterior hormones. It's a short prodromal period, which has a poor prognosis. What is this? Office potonus position that this baby is in at the moment. This hyper extension of the neck along with the spine, and the patient is very. This is trismus. Trismus is the classified facial features. There's a lockjaw type syndrome that can be seen expressing in this picture. Now, the entry wound may show a localized small area of cellulitis. Exudate or aspirations may give a sample that can stain to show the presence of gram-positive rods within it. Prophylactically, however, you give tetanus toxoid. It is the best preventive treatment. But, however, treatment in an established infection requires debridement of the wound, along with antibiotic treatment with benza and saline. Now, relaxants may also be required, okay, since it causes spasticity, and the patient may require ventilation as well in severe forms, because they can have a respiratory collapse associated secondary to bronchospasms, which may be associated with a high mortality as well. The use of antitoxins using human immunoglobulin ought to be considered for both at-risk wounds and established infections as well. Prophylactically, usually tetanus toxoid is known as the best preventive treatment method. But if established root infection, it's better to have a minor development of the wound, followed by a antibiotic treatment. Also, with it, relaxants can be given. Synergistic spreading. Synonym is term for subdermal gangrene or even necrotizing infections. This is not caused by Clostridium. It's a mixed pattern of organisms which are responsible. It's coliforms, staphylococcus, bacteroids, anaerobic streptococcus, and Cryptosporidium. They have all been implicated in acting in synergy together. Synergy means that they all act together. Abdominal wall infections are known as melanocytic hospital gangrene, and scrotal infections are known as Fournier's. These are just terms basically according to the site that they know. Their abdominal wall conrhophagia is a synergistic infection known as melanocytic hospital gangrene, or if it's involved in scrotum, it's known as Fournier's gangrene. Here we have a picture of melanocytic gangrene. That's involved. That's the picture. That's what it looks like. And obviously over here we have Fournier's gangrene involving the scrotal area and the scrotum. Now, patients are usually immunocompromised, like for example diabetes mellitus patients, and the wound would be minor but severely contaminated, and those are more likely to be the cause. For severe wound pain, we see signs of spreading inflammation can be seen with reptics, obviously you gas gangrene development, and smell, along with the rest of them are all the signs that are seen of this, that show that the infection is spreading. Subdermal spread of gangrene is always much more extensive than appears to be from initial examination. And untreated will obviously lead to widespread gangrene and multi-system organ failure. Broad spectrum antibiotic therapy is usually given along with aggressive circulatory support. Taken locally, the therapy do extensive debridement or even amputation if needed. Now, infections complicating a surgical procedure, which can be obviously wound infections. They're the most common complications of the surgical sites. Now, primarily, classification of these sources of infection primarily acquired from endogenous sources, such as that following perforated peptic ulcer, or secondary, exogenous, and these can be acquired from operating theater, such as hospital-acquired infections, such as with air filtrations or something. Ward and poor hand washing compliance from staff or attendants or the patient, him or herself, or from contamination at or after surgery, such as an anastomotic leak. Surgical site infections, SSIs. The infection of a surgical wound can be defined as invasions of organisms through tissues, followed by breakdown of local systemic host defense. Take a local dosage of wound. Basically, there's a break in the field promoting the access of the infected organisms. And host defense meaning malnutrition or comorbidities such as diabetes, leading to cellulitis, lymphangitis, abscess formation, or even bacteremia post-operatively can occur. And surgical site infection typically occurs within 30 days after surgery. So that is your grade period in which surgical site infections can occur. Now, what are some of the types of surgical site infections? You have organ on space, deep incisional, superficial incisional. Superficial incision occurs just in the area, obviously, of the skin where the incision was initially made. Deep incision occurs beneath the incision area, in deeper tissues such as muscles or in fascias, and usually surrounding the muscles. Those are known as deep incision surgical site infections. Organ or space, and this is the dead space that we talked about earlier, that if left behind can lead to collection of inflammatory markers or even hematoma, serous fluid that can become infected. Or it can also be the organ. So this type of infection can be in any area of the body rather than skin, muscle, and fascia involved in the surgery, such as body organ or space between the organs as well. Now, major and minor surgical site infections. Major surgical site infections is defined as a wound that either discharges significant amount pus spontaneously or secondarily due to procedure to drain it. Now, patient may have systemic signs such as tachycardia, pyrexia, raised white cell count, and obviously systemic inflammatory response syndrome might be there as well, along with its signs and symptoms. This is classified as a major surgical site infection. A minor wound infections may discharge pus or the serous fluid, but should not be associated with excessive discomfort, systemic signs, or delay in return. So minors should still proceed with either a post-operative antibiotics, dressing cares, which is in daily dressing, requires wound cares, and early return home, discharging the patient and preventing them from further hospital-acquired infections. There's a picture of a major surgical site infection. Obviously, you can see it's not just limited to the superficial dermis, epidermis. It's definitely deeper, and yeah. Here's a minor in the middle, if you can see right here. The rest of the wound seems to have healed quite well. The margins are closed, and yeah, except for out here, it seems like it's usually probably a superficial infection of the surgical site. And surgical site infection rates relating to the wound contamination. All right, type of surgery. If you have different types, right? You can categorize them into amount of wound contaminations involved within that surgery. It could be clean, just no viscous is open. For example, thyroidectomy, thyroid gland, yeah, mastectomy along with the breasts. Its infection rate obviously come at 1 to 2%, and the rate before prophylaxis is also 1 to 2. Now, moving on, you have from clean to clean contaminated. This means viscous or open viscous in the sense that is reaching the peritoneum. And there's minimal spillage that could be associated. It's also known as clean, it comes under as clean contaminated. Intestinal, for example, polycystic involving removal of gallbladder. Usually gallbladder can be prepared and result in small amounts of bile leakage. So it will still be considered as clean contaminated. Infection rate in these types of surgery is less than 10, and the rate before prophylaxis, associated with gastric is 30% and biliary is 20%. Moving on to the next, we have the contaminated ones. This may open viscous with spillage or inflammatory disease, such as appendectomies, intestinal anastomosis. There is a definite spillage, there's an open viscous, and or a inflammatory disease. Infection rate is obviously more than 20, and rate before prophylaxis is up to 60%. The fourth category is a dirty type of surgery in which there is pus or perforation or incision. There's a example of that would be an abscess drainage where infection rate is less than 40 or up to 60% or more rate before prophylactic treatment. Now, major and minor surgical site infections. Differentiation between major and minor in the definition of surgical site is important as well. There are scoring systems in order to score the severity of the wound infections, particularly used on surveillance and research as well, in order to improve better care for surgical sites and prevent them from infections. The asepsis wound score, asepsis, A-S-E-P-S-I-S wound score, the Southampton and wound grading system. Now, what are the criterion points for a sepsis wound score? This measure had additional treatment, antibiotics for wound infection. These are the criteria for it. Drainage of pus under local anesthesia, debridement of wound under general anesthesia, because obviously is either in an area where it's required the patients could it's usually where the risk chances wasn't plus it could be deeper or involving cavities, abdominal thoracic cavities. So obviously the wound scoring is much worse compared to local anesthesia, drainage of pus under local anesthesia. Serious discharge daily, you get 0 to 5% erythema, purulent exudate, separation of deep tissues, isolation of bacteria from the wound, stay as inpatient prolonged over 14 days as a result of wound infection. तो ये सब चीजें additional treatment में जो है वो सब for A. S for serous discharge, E for erythema, P for prevalent, S for separation. I, isolation of bacteria. Stay, S, stay as a patient prolonged. Stay in the hospital for more than 14 days. Yeah. It's scored for 5 of the first 7 days only. Southampton wound grading system is based on the grade appearance. Zero जो है मतलब कि normal healing, ठीक है. That's the first grade. 0. अगर bruising है सिर्फ थोड़ी हल्की, you want A, considerable amount, or ज़्यादा B, and then mild erythema along with it, C. 1C. Second grade is erythema plus other signs of inflammation. ठीक है, वो क्या क्या हो सकते हैं? 2A at one point, मतलब involving at one point. 2B around the sutures. 2C along the wound. 2D along the wound. Sorry, 2C along the wound, and 2D around the wound. ठीक है, along the wound मतलब कि it's still it's not just around the sutures, but it's along the wound. And around the wound मतलब कि it's completely involving the wound as well. Third category, third grade is clear or hemoserous discharge from the wound. 3A at one point only, usually of 2 centimeter. 3B along the wound, more than 2 centimeter. 3C large volumes, and 3D prolonged for more than 3 days. Major complications जो है उसमें 4 जो है वो plus है. 4A at one point again, 4B along the wound, or further of grade 5 will be deep or severe wound infection with or without tissue. Now this may obviously breakdown here, hematoma requiring aspiration will be obviously better to cover. Other infections complicating surgeries can also be chest infections, UTIs, urinary tract infections, intravenous central line infections, infections of implanted prosthetic materials can also be another pseudomembranous colitis, usually caused by Clostridium difficile. Inappropriate sequential use of several antibodies puts patients most at risk. So the key symptoms of bloody diarrhea, pseudomembranous and elderly are particularly at risk. Severe colitis may lead to perforation, need for emergency colectomy. In that case, there's a high mortality associated with it, and treatment usually involves antibiotics through immunazole or antibiotics. Now, we're briefly looking at prophylaxis. Take a treatment which is given or action taken to prevent the disease from happening. Avoiding surgical site infections means your staff should always wash their hands with weak patients. There are one patients who wash your hand once to the next. That's necessary. Length of patient stay in hospital should be kept to as well. Pre-operative shaving should be avoided if possible. Antiseptic skin preparation should be standardized. Attention to theater technique and discipline. Avoid hypothermia, perioperatively, and ensure supplemental oxygenation in recovery is available as well. The choice of antibiotics for prophylaxis can cause the empirical cover against the expected pathogens. Obviously, single shot IV administration of infection of anesthesia. Repeat only in prosthetic surgeries, long operations, or if there is excessive blood loss. Right. Continue therapy if there's unexpected contamination. Benzalkazine should be used if Clostridium gas gangrene infection is possible. In patients with heart valve disease or prosthetics should be protected from bacteria caused by dental work, urethral instrumentation, or visceral surgeries. Now, bacteria is involved in surgical infections. Streptococci, beta hemolytic streptococcus is a type of streptococcus which features latent pathogenic ability to spread and cellulitis conspecific, and then also deeper into the tissue involved. Streptococcus faecalis is found in synergy with other organisms such as gamma hemolytic streptococcus, streptococcus, which is anaerobe. Staphylococcus Staphylococcus aureus, Staphylococcus epidermidis. Clostridium species can also be significant. These are gram-positive obligation. Clostridium difficile is one of them. Clostridium tetani and Clostridium perfringens. Difficile is the one that causes pseudomembranous colitis, like we discussed. We have an anaerobic gram-negative bacilli category as well, bacteria. This may E. coli, Klebsiella, Proteus, Pseudomonas, or Bacteroides species, Bacteroides fragilis. Can be associated with type of surgeries as well. This may include either vascular or orthopedic, GI, esophageal, gastric. It may specifically also depend to the type of surgery. Vascular metastasis, you will encounter Staphylococcus epidermidis, aureus, or anaerobic negative bacilli. In a prophylactic regimen suggested are 3 doses of fluoxetine with or without gentamicin, vancomycin, or rifampicin if mRCNS or cell-resistant Staph aureus is addressed. Orthopedics, man, you gotta be on the lookout for Staphylococcus epidermidis or aureus, and 1 to 3 doses of broad spectrum cephalosporins are usually efficient enough for gentamicin needs. Esophageal gastric surgeries, you may encounter enterobacteriaceae, enterococci, including anaerobic or virulent streptococci, 1 to 3 doses of second generation cephalosporin along with maternal and severe contaminations. If you're doing biliary surgeries involving the liver and the gallbladder, then enterobacteriaceae, mainly E. coli, and 1 dose of second generation cephalosporin is suggested. Small bowel surgeries may enterobacteriaceae and ropes, and again, 1 to 3 doses of second generation cephalosporins with or without metronicum. Appendix, colorectal, is may enterobacteriaceae and ropes, mainly bacteroids, and 3 doses of second generation cephalosporins with metronism. The use of orally absorbed antibiotics is controversial in the appendix colorectal surgeries. Viral infections. Again, when discussing viral infections, we need to discuss Hep B and C along with HIV infections. Universal precautions should be taken when there's a risk of splashing during the procedure. So you need to take all kinds of protective measurements, particularly with power tools. Where is power tools most commonly used? What type of surgery? Orthopedic surgery. Use of full face mask, ideally, is always recommended, along with protective spectacles, like wear goggles, or even a face shield, to prevent from these splashes or particles. Use of fully waterproof disposable gowns and drapes, along with them, particularly during serial conversions. Boots to be worn, not clogs. Clogs are basically sort of a raised form of shoes that normally surgeons do wear, but there are still areas where your feet is a little exposed. The boots completely covers your feet up to your basically lower leg, ankles, and everything else. So boots are definitely recommended over clogs to avoid injury as well from drop sharps. That you will be exposed to area foot butt if there's sharps like needles, blade, so many things on the operation table that could drop and cause an injury onto your foot. So double clothing if needed. Take a large size on the inside. A larger size on the inside is more comfortable usually, and allow only essential personnel in theater. Avoid unnecessary movement in theaters as well. Limits the accident from happening. Respect is required for sharps. Take note with passage in a kidney dish. What is a kidney dish? Kidney dish is a kidney or a bean-shaped dish in which it's recommended that we pass all the sharps. Sharps can also be usually commonly through blades, surgical blades, and respect should be given in handling sharps as well, in the form that you pass it along or store it on the operation table. A slow, meticulous operative technique is needed with minimized bleeding. And that is it for today. That's all we have for today for surgical infections. I believe we still have a few minutes left. So if you guys have any questions, please don't hesitate. And otherwise, thank you very much.